and welcome to our first Rural Doctors broadcast for 2010. I'm Jerry Gannon, and thanks for your company once again. Tonight our program focuses on the skin. While rarely life-threatening, the problem of differentiating between various rashes and skin conditions and being confident in your diagnosis can be a significant worry. So tonight, dermatologist Dr. Kurt Gebauer will talk through the differential diagnosis and treatment of as many skin conditions as we can fit into the program. A little later, we'll also look at some of the online dermatology resources available to GPs. But for now, let's join Dr. Olga Ward as she asks Dr. Kurt Gebauer about rashes.
Kurt, welcome to the program.
Thank you for inviting me back.
Kurt, could you tell us about how to assess a skin rash?
I think our first image here is of a hand. Hands and feet are different in that anyone who has a hand or foot rash, the first golden rule is always do a skin scraping. Because unfortunately, patients aren't always honest or comprehensive with their history to you. Always assume they've put something on it, they've borrowed something from their cousins or they had something in the cupboard. So quite frequently what you're looking at may not be the original rash and it's been disguised by some previous treatment. And patients for all sorts of reasons forget to tell you the full story, and that goes with everything. So the number one is scrape it. A couple of times a year I get caught out, or rather not get caught out, because I send them all off to get scrapings where I'm quite happy it's an inflammatory process and I get a belated fungal result back positive. Mm-hmm. With hands, the most common rash is irritant contact dermatitis, and that's all in the name. It's basically wear and tear. So I tell patients, I use the analogy, if I put my hands in battery acid of my car, I get a rash. So that's just wear and tear, and there is no test, there is no way of proving that. It's a clinical diagnosis or a diagnosis by exclusion. Very rarely allergic contact dermatitis does happen. In the community, it's always allergy, it's always infection. But in reality, from our point of view, it's nearly always irritant contact, and allergic contact is a very small group. The Europeans routinely go ahead and test everybody. I think for our system that's probably a little bit too labour intensive. Manage patients as you think is appropriate.
When you say test them, you mean patch test them for what they're allergic to? So I thought that you couldn't get a lot of the Australian flowers and plants and things to actually patch test.
Quite true. So patch testing, I use the word allergy patch testing to my patients, is a way of assessing whether they have a type 4 immunological reaction, so it's a cell-mediated reaction. Patients frequently mix up prick testing, which is type 1 and predominantly useful for aeroallergens, asthma, hay fever, and occasionally for food reactions, but very rarely. So from a dermatologist's point of view, doing RAS and aeroallergen blood tests really isn't very useful for any of our patients, and certainly prick testing is marginally helpful in a very small group of patients. But where you have a fixed rash that's not responding to what you think is reasonable treatment, and you've done a skin scraping, and you've given the patient 1 or 2 or 3 decent treatments, then probably that's the role of allergy patch testing. For country patients, a real pain because they have to come to town. There's not many of us that do it. I'm one of the very few that will do it. And they need to be in town for a week. So traditionally, appointments are on a Monday, then a Wednesday and a Friday.
So patients often turn up with a really undifferentiated rash, just, a red spotty thing. How do you tell which ones of those you worry about?
It's really comes down to skill. Like most of the diagnostic labels that we use are old words, Latin, Greek, described 100 years ago. So really the labels that are used, varicose eczema, dermatitis, are quite confusing. Essentially, the word eczema means bubbling or boiling in Greek to reflect that sort of lumpy, bumpy, itchy rash that we see. It'd probably be best if we deleted eczema from our curriculum and just used the word dermatitis for everybody. In workers' comp, for some bizarre reason, if you put eczema on a form, the insurers will often reject it, but if you put dermatitis, they accept it. Why? It's just one of those old things that we come up against. And essentially I'm not, as a practitioner, really that bothered about the label. It's really the history. What's bothering the patient? How itchy is it? Where is it? And then that's the information we use to try to work out a management plan. I'm not so fussed about the label that we call it. So essentially, if the patient's got an itchy red rash, then we're going to need to settle them down, and it really gets down to the therapy. And after you've seen half a dozen or 20 or 50 or 100, then you start to get better at the therapy. Yep. And really, why did it happen? We're not very good at that at all. And you would have seen, and I see continually patients who come along and go, I don't have asthma, I don't have hay fever, I didn't have any rashes when I was a kid, and I've got this all over itchy red thing that I've been scratching at, and it's only been there for the last month. Probably most of those are set off by viruses. We honestly don't know. So
how do you begin treatment, say, for somebody with some contact dermatitis or a defined area of dermatitis?
I differentiate basically soft, thin skin, thick skin. So basically patients who will have facial lesions, neck lesions, axillary lesions, genital lesions, you need to be careful with therapy, because they're the areas that you may, if you're very unlucky, have some problem with the prescriptions that we use. Patients are steroid phobic. Unfortunately, about the only thing that we can prescribe in our country are steroid creams. There is Elidel, which is pymacrolimus, which is a non-steroid, and that was marketed aggressively on the fact that it was a non-steroid, but equally it wasn't terribly effective. It really only works on extremely thin skin, and it quite frequently stings. So when you prescribe Elidel to patients, you have to warn them that very frequently this chemical will sting and that they'll need to persevere through the stinging. So unfortunately, therapeutically, we have a range of steroid creams and very little else. Yep. For very chronic lichenified dermatitis, so people have been scratching for years and years and years, once we've settled down the itch with the prescription steroids, we will then move into tar creams or emollients as a long-term way of improving the quality of their skin. But for the acute rashes, you need to select a steroid cream. And because there's a variety, it's probably a bit like blood pressure pills. Learn 1 or 2 or 3, get used to using those and just stick with those. There isn't that much value on flitting from one to another, because roughly they all work the same. The larger the tube, the least effective it is. The smaller tube, the more effective it is. But the main reason patients don't respond is because they don't follow your advice. Yep. So the number one thing is you need to do is, what have you actually done? Bring your tubes in, measure the tubes, look at the tubes, assess what volume of cream they've put on. I always go to great lengths, and most dermatologists use fingertip units. So if we're dealing with a hand, then I want patients to use half a fingertip. So we use our index finger, and I always point out and say half a fingertip. I talk about a frozen pea, or occasionally I talk about a plum. So if I want someone to be using a cream on their face, they probably need 1 full fingertip unit, whatever the cream is that we're using, to adequately cover that area.
Yeah. Cream or ointments?
We prefer ointments. So dermatologists nearly always prescribe ointments, and the reason we prescribe ointments is because ointments, being greasy, it penetrate better. So for the same volume of cream that's applied, you get a much better therapeutic response. The other thing about ointments is ointments are free of preservatives, so you don't get as much stinging, you don't get as much irritation. And some ointment formulations, so for example Celestone or Betnovate creams, are quite drying. So it seems unusual in that the cream, when you feel it, it's quite thick and it's smooth, and patients like the cosmetic feel, but if you're using those creams on a dry, scaly, flaky rash, you'll get a short-term therapeutic response, but the dryness persists. And because patients are putting 1 cream on already, they're not so good at putting their moisturisers on. So dermatologists nearly always prescribe ointments. I make sure that I write on the script ointment, I print it and I underline it, and I tell the patient that they must get an ointment, because unfortunately, frequently, you will say one thing, you'll prescribe one thing, and you'll assume that the chemist will do what you said. Unfortunately, that occasionally, possibly I'd say frequently, doesn't happen. And that's another reason why we have therapeutic failures. Patients will come back and go, that stuff you gave me didn't work. So we go, okay, then I'll go back, well, what did the chemist give you? How did you use it? How much have you done? What was your method of application? I go through all those things first before I reach for the script pad and give the patient another cream or ointment, because you may well find the same thing happens again.
Yeah. So what do you do with the patients who absolutely flatly refuse to put on steroid preparations?
Well, there's 2 options.
Tell them to itch.
Well, one of my colleagues, who I won't mention his name, he actually says to patients there are treatments that are tried and tested that work. That's what I use. And there's things that don't work, which you're free to use. That's not the words I would use. But I do say to patients that anything you get over the counter isn't going to be particularly useful or effective or powerful. The only things that you can get that do really help your condition are things that we will prescribe. And patients are free to do whatever they want, but the unfortunate fact is that if they're particularly itchy and inflamed, they're going to need to use a topical prescription, and that's all we have. And I've had some patients who will refuse to use topical agents, and we have to give them systemic treatment. So from my point of view, I find that's bizarre. They'll take a tablet, but they won't use a cream.
Now, some patients tell us that they're allergic to very innocuous things like sorbolene cream or Aqueous or Cetaphil.
Yep.
Is that really an allergy, or are they just getting stinging? And what would you do with them?
Scientifically, allergy is actually quite rare. It's always worth for us as doctors to keep in mind it's not hugely rare for patients who've had chronic skin disease for a long period of time to become allergic to the ingredients that we prescribe. Mm-hmm. So you quite frequently find as a general practitioner you may refer someone off to a dermatologist, and the first thing they do is stop all the treatments you've given and prescribe a totally different class. And the reason we do that is twofold. One is there's a thing called tachyphylaxis, big fancy word to say people get used to the things that we've been using for a while, and also we're factoring in for the allergy component. In Europe, chronic dermatitis patients, roughly 10% will be allergic to a preservative in a prescription cream or the actual steroid ointment itself. Sorboline's a little bit different. Australia, we use sorboline. In England, they use E45. Different countries have different creams. Anyone who's come from Queensland, they use a lot of peanut-based oils. Mm-hmm. And any moisturiser that moisturises is fine from our point of view. But sorboline is well known in Australia. It's cheap. It does have one preservative in it. And patients who are extremely dry, so when you run your hands across their skin and you feel that they're dry, will often sting with sorboline, particularly children. But there are a range of moisturisers that you can find, and patients who have dry, flaky skin or inflamed skin all need a moisturiser. Red skin, increased blood flow, increased growth. So they will always have dry skin, they will always have a damaged skin barrier, and we need to improve that long term, and they need a moisturiser.
Yeah. Kurt, we were talking about eczema and dermatitis, and I know some patients come up with discoid eczema, and we've got a photo of that. How do you tell the difference between that and the next image, which is of a fungal rash, which looks very similar to me?
Yes. Discoid eczema is an unusual rash. I don't understand what's happening immunologically, because you'll get these patients who'll come in and they'll have a very round, regular, symmetrical rash. Another name is nummular dermatitis. Mm-hmm. And if the patient has only one or two lesions, it can be extremely difficult. And again, as we mentioned, they've often put a whole range of creams on it. So the number one thing is you're faced with ringy rashes, do a skin scraping. Okay, experienced people out there will go, well, hang on, I'm not going to get a result of my skin scraping for weeks.
Yep.
Next thing is treat the patient. What's the symptoms? Patient's itchy, patient's uncomfortable, so treat that first. Don't worry about if it is a fungus and you've used a steroid cream. Well, all you're going to do is make the patient less itchy. The patient will become more comfortable. The lesion won't go, but it will settle and it will spread over the next week or two. Then you get your results back and then you treat the patient with your antifungals. So the number one thing, assume it's inflammatory, treat them for eczema, treat them for dermatitis.
Psoriasis, another common thing that we see in general practice.
Psoriasis is incredibly common. 3 to 9% of the population will have psoriasis. The rheumatologists come in at the high end. They'll say it's about 9%. Dermatology literature is about 3%. And the honest answer is we don't know, because what do you call psoriasis? Somebody who has an itchy bottom, someone who has an itchy ear, someone who has quite heavy dandruff, that's all psoriasis. And seborrheic dermatitis, which is a separate diagnostic label, is really in the same psoriatic family. So quite frequently you'll see patients who have obvious facial sebderm and they'll have psoriasis on their elbows and knees. So although they put these in different chapters of the textbook, it's exactly the same process and it's really a continuum. Mm-hmm. The thing about psoriasis is psoriasis traditionally doesn't itch. Flexural psoriasis will itch. So rashes in their ears, genital areas, scalps are frequently very itchy. Patients will frequently pick and scratch rough bits of skin, so once you start damaging it, the Koebner effect, the psoriasis patches will become worse, will become more inflamed. And any rash that is red generally is itchy. Sunburn is red, it itches. Grazes are red, they itch. And certainly psoriasis will itch a bit. But there are many different patterns, and at the moment we clump all these things together as the one disease, psoriasis. In 5, 10, 15 years, we're going to be a little bit more sophisticated. we'll have genetic testing and there'll be subgroups, because there are subgroups of treatment. The patterns are also quite consistent. So someone who has elbows and knees doesn't over years become fulminant psoriasis. People who have rashes in their scalp often have rashes in their genital area at some stage, but they don't get the elbows and knees. So they are distinct subgroups clinically, and we treat them differently.
Yeah. What about the patients who get those horrible pustules on their hands and feet?
There are two types. Straightforward palmoplantar pustulosis is a process which is particularly in mature females. So the 50, 60-year-old age group will come in and they'll either have bilateral or unilateral, sometimes it's a palm, but often if you look, you'll find them on hands and feet. And they're essentially asymptomatic. They'll just show you these pustules scattered over their skin on their hands and feet, and it's just appeared. Some international authors will say this is all a variant of psoriasis, others will say it isn't. Essentially, skin scrape again. Biopsies aren't particularly useful for any of these conditions. Doing skin biopsies, you just end up with 2.5 pages as description and 1 paragraph of conclusion from the pathologist, and it really doesn't help you very much. Topical therapies for palms and soles don't work very well at all. Frequently, I do start with topical therapies, and that's part of managing the patient, because they come in, they show you a rash, and then you start talking to them about tablets. Occasionally they get a bit spooked and you don't see them for a long time. It takes the patient a while to adjust to the fact they're going to have a difficult management problem, and we're going to need to be giving them treatment. So I always give them topical treatments. That's one place where tars and acids work quite well. So 6% salicylic acid, 6% LPC in a base. I use emulsifying ointment. But if you're up north, you may want to use aqueous cream. It's very hot in summer, again aqueous cream, and as you go into winter the thicker bases are better.
So you're just looking to take the scale off there? Or
what the acid does is get the crust off the scale, and the tar, it's arguable, but it usually does improve the quality of the skin. And then once we get the scale off, the most potent topical steroid that you can prescribe. So things like Alicon, Alifrat, Diprazone, any of the smaller sized tubes. Probably the easiest obtainable most potent topical steroid in Australia is Diprazone OV, and most pharmacists stock that, but it's not on the PBS and the patient has to pay for it. From a dermatologist's point of view, we often use light treatment, which isn't terribly practical for country patients because there are no light machines and access is not there, and frequently you need systemic treatment. And for those palmoplantar pustulosis, for some bizarre reason, systemic antibiotics like minomycin or erythromycin is usually the most effective. We don't know why. We suspect it's because they have prominent anti-inflammatory factors, as opposed to we're not very keen on systemic steroids for chronic rashes, and some patients do need to go into the more heavy-duty medications like azathioprine and methotrexate.
Okay, so if you've got a patient with, say, just the standard psoriasis, but they've got the really big plaques, the big thick plaques, would you mostly treat them in a topical fashion, or do you give them systemic treatment?
For chronic plaque psoriasis, the ones you see most commonly in practice, like elbows, knees, the big patch on the sacrum or the thighs, any rash that's more than 20% body area is extremely difficult to treat with topical therapy. So if you're looking at a patient and you get their clothes off and you assess that they've got a lot of rash, assume that it's going to be very, very difficult for them to put cream on. And equally, if they're a male, they're a lot less compliant and a lot less enthusiastic than females. It's true to say that men are generally hopeless. Or if you have someone who lives alone and they've got a rash on their back, they can't treat it, you need to ask those questions. But for elbows and knees, for psoriasis, if it's very thick, elephantine and crusty, then a salicylic acid or a urea creams to remove the scale is probably the first thing you want to do. So give them a topical keratolytic, and again on the PBS, 6% salicylic acid and aqueous cream. It's easy to get hold of, the chemist can make it up. Get them to do that for 2, 3, 4 weeks, leave it on at night. Salicylic acid cream's white, it's clean, it's easy to use, get the scale off. And then probably the next thing is Davonex. So Davonex worldwide is the most commonly prescribed topical agent for psoriasis, that's chronic plaque psoriasis. And now that Davobet has become on the PBS, which has just happened in the last couple of weeks, Davobet has its advantages as well. Previously, the main disadvantage of Davobet was its extreme cost, and most of the patients couldn't afford it, but now with the PBS supporting the price, that's also worthwhile as a choice. The thing about Davonex on its own is Davonex is very slow. Australians expect a cream to work in 2 days, otherwise they won't use it. So you need to counsel the patients to use an adequate volume, and that they need to do this for at least 2 to 3, 4 weeks, then they'll see the results. Any patient who uses things for 2, 3 days and puts it to the side, they're not going to get anywhere with Davabet or Davanex. But for those who will comply, it's probably the best agent. You don't get tachyphylaxis, you don't get atrophy.
If you've got a patient who's got very chronic psoriasis, and I see patients who've got chronic guttate psoriasis, or they've got a few plaques and a few other bits, is it worth starting them on systemic therapy in general practice in the country, or should they be perhaps reviewed by a dermatologist first?
Our position is that if it's greater than 20% body area, you're probably worthwhile sitting down with the patient and go, look, we really don't think topical therapies are going to fix this problem. Some patients come to terms with their psoriasis. You'll move into an area and you'll see someone who comes in and go, gee, that's terrible psoriasis, and they'll go, yeah, it is, it's a problem, but I've always had it and I've got used to it and I really don't want any treatment whatsoever. So if the patient is satisfied and come to terms with their disease, then we don't need to treat them. Keep in mind that psoriasis is not just a skin disease. All doctors know about the arthritis component, but some people do get iritis, some people do get inflammatory processes internally. It's a systemic hematological process that predominantly presents in the skin, and the dermatologists are the ones that traditionally have treated it because that's where it first turns up. Phototherapy, again, is not practical, but in Bunbury and Geraldton there are phototherapy machines, but for the rest of WA, nope. Some people can get a little bit of natural light and they find that works quite well for them. 10-15 minutes of bright light each day isn't really going to increase their skin cancer risk horrendously. I've had a couple of country patients, and I remember one lady who lives in Esperance, where it's a little bit harder in winter to get natural light. She jumps into the local solarium. So that's not ideal because solariums aren't the same as phototherapy machines, but from her point of view, she has widespread mild chronic plaque psoriasis, sort of guttate type, and a solarium trip twice a week for winter keeps the skin under control, and that saves her having to go on to systemic therapy. But the answer to your question is, if you're, as a general practitioner, you're happy with the diagnosis, you're used to using these drugs, and a number of patients have worked in dermatology units or worked in rheumatology units and are quite used to using methotrexate or azathioprine or cyclosporin. If you understand these medications and how they work, by all means, treat the patient. You don't need me to say, hey, you need to do this, this and this. So if you're quite comfortable doing that, we'll go ahead and treat the patient. Shared care works very well too. So occasionally people will say, well, what do you think? Okay, you start them off and then you tell me what I need to do, how frequently do I need to do blood tests, what do I need to do, and patients get shared. That works very well if you feel less competent or confident. And it's like everything, it's a skill. Once you have treated a number of patients, you work out how to do it and you can do it yourself.
Yeah. And do you have any really hot tips for treating the manky nails that come with the psoriasis?
Yeah, nails is probably the hot tip as such is that if they have pitting of their nails, it's very likely that they're going to go on and develop severe inflammatory arthritis. So if you see pits, that's a sort of mental note to you that this person's going to have inflammatory disease in their joints, either now, and some patients will ankylose their spines without any pain or any inflammation whatsoever, and others will end up with having quite severely inflamed joint disease. So it's not gout, it's not trauma when they turn up with a red inflamed toe. It may be, but it's more likely going to be psoriasis. And the only thing that really works effectively for nails is systemic therapy. We do try with Davanex, rubbing it on twice a day, using steroid lotions. Steroid lotions are more effective for onycholysis. So onycholysis is where their nail peels back, and that's a real bugger because it catches on everything and then they get dirt underneath and they sort of start cleaning, and that trauma causes more problems. So a steroid lotion, Novazone, Elicon, Advantan, applied to the nail bed, so get them to hold their thumb down or their nail down just to open up that gap and put a drop of lotion on every night, massage it in. Frequently is very useful for onycholysis, but for the pitting or that degenerate crumbling nail, we'll often use topical steroids, but frequently find the patients aren't hugely compliant, or even when they have been very good, it doesn't work terribly well.
Do they go away if you've got the patient on methotrexate? Does that improve?
Systemic treatments that work, And methotrexate probably is the most commonly prescribed treatment. It's been around for 50 years or so, works very well, it's very predictable. The only problem with methotrexate is patients cannot drink alcohol. And that is a real problem for most of us in Australia, and anyone that works up north, they look at you with horror. But the clinical tip with inflammatory diseases of the skin is you give them a decent dose to start with. Patients, and probably us, we think, oh, we'll just give them a little bit and we'll just see what happens. What happens is you end up chasing the rash. So you get a partial response, so then you push the dose up and then the rash flares, and then push the dose up, the rash flares. So with dermatology patients, you give them a reasonable dose or even a slightly higher dose. Get control and then bring the dose down over months.
A little bit like asthma, hit it with a nuclear bomb first and then back off afterwards.
Exactly. You want to give them a decent treatment. And then you can back off, and you can back off, and often you'll find you'll get people well maintained with really quite low doses. I've had lots of patients on 5 milligrams or even 2.5 milligrams. You know, females that are 40, 50 kilograms in weight, and that controls their disease. Men being heavier, 10 milligrams to 15 milligrams will control most men. And we're talking methotrexate. Methotrexate works brilliantly for chronic dermatitis. It's not just a psoriasis drug. Traditionally, we will often use azathioprine for dermatitis, and we use methotrexate for psoriasis, but both will work in most patients for either disease. So get to learn to use one, become comfortable with it, become competent, and use it.
Dermatologist Dr. Kurt Gebauer there with Dr. Olga Ward, and we'll return to that discussion shortly. Now, while differential diagnosis is sometimes tricky, the good thing about skin conditions is that they're right there for everyone to see. So there are ways in which dermatology lends itself to telemedicine and other forms of remote support. In fact, it's an area of medicine where a good digital photo can save a lot of time and worry. Both RACGP and ACRRM provide access to online dermatology resources and support services for rural and remote GPs that you might find useful.
Both RACGP and ACRRM have dermatology resources available for rural and remote GPs that can be accessed online. ACRRM offers its members Telederm National. This website provides ready access to specific advice on a wide range of skin conditions, as well as online education in dermatology. It can be accessed via password by medical students, junior doctors, registrars, general practitioners and specialists. As well as education, the aim of this service is to reduce the need for Australians to travel or wait months to get specialist advice for their skin problems. Rather than reproduce what's available in textbooks, a case-based approach to dermatology is used. You're presented with a clinical problem and you work your way through a series of questions. The aim is to show you how to diagnose and manage the problem. The questions explore clinical assessment, relevant history and investigations, and finally treatment. The answers are available at the click of a mouse. Once you've worked your way through the case, a short multiple-choice questionnaire is available, which, once completed, earns you continuing medical education points, which are automatically recorded. The cases are indexed in alphabetical order. If you see a patient with one of these conditions or want further information, you only have to click on the condition to get instantaneous advice. Each week, subscribers receive a quiz via email. Responses are posted and a final answer is put up after a week. The site also offers other external information, such as reviews of interesting articles from the latest journals and links to other useful sites. There's also sections with online tutorials outlining basic surgical skills, as well as videos demonstrating incision and suture techniques and skin examination. Telederm National also provides an online consultation service. If you want advice, you only have to send clinical details and, if needed, a digital photograph. You'll receive an answer and advice on your case within 24 hours. For medico-legal reasons, you first have to acknowledge that ACRRM only provide advice, not treatment. An online consultation may not be as good as a face-to-face one with a dermatologist, and that your patient has agreed to you using the service in their case. To protect privacy, no identifying patient details are sent, other than age and sex. To use the service, you simply need the ability to email and attach an image. The Royal Australian College of GPs also provides a link from their website to Dermis, an online visual atlas that provides information on almost all skin conditions. There are different ways to navigate through Dermis. You can simply search directly for the condition you want more information on, or search by letter or by locality on the body. The site offers various visual examples of the condition to aid you in your diagnosis. As well as the visual atlas, the site offers information modules, an in-depth look at various conditions. These modules offer information on identification, differential diagnosis, prevention, treatment and management, as well as plenty of other useful information about the condition. Dermis also provides useful links to other organisations and journals, which you might find interesting.
Some good resources and services there that could save you and your patients some worry, not to mention unnecessary trips to town. Now let's go back to Dr. Olga Ward and dermatologist Dr. Kurt Gebauer as they discuss the diagnosis and treatment of rashes.
Kurt, can we talk about something that's a little more unusual, at least in Australia, and that's lichen planus. I know a lot of us see white things in mouths and start freaking out about them. Could you tell us a little bit about lichen planus and how we diagnose it?
Certainly. Lichen planus it's a mysterious condition. Essentially, for the scientist, the model of lichen planus is graft versus host disease. Mm-hmm. So essentially what's happening is there's a lymphocytic mediated attack on skin keratinocytes. So that's what's happening for the scientists. But if you look at the distribution pattern of lichen planus around the world, so people who've trained in England, they see lichen planus all the time. Skin lichen planus, oral mucosal lichen planus is extremely common in the UK. In Australia, it's becoming more and more common. So I've been in practice for 20-something, 30 years, and now I'm starting to see more and more lichen planus. We did have some of our senior dermatologists who were working in this community 40, 50 years. It was extremely rare to ever see lichen planus 40, 50 years ago. So we're seeing more commonly, and most of the patients we see, certainly in my practice, are English-born, Indians or Europeans. Mm-hmm. So it's a certain group of people who get this. So long-winded answer in that we suspect it's a virally induced process that after years then causes this characteristic condition called lichen planus.
Now, can you describe what we're seeing on the slides in those mouth lesions?
So in the dentist's point of view, and sometimes patients come from the dentist, mm-hmm. what they will see is the classic Wickham striae. There's those white lacy lines that you can see in the picture. The more severe patients will have inflammation. Lichenoid skin has a very characteristically purple, plum-coloured, not a red, it's a very purple inflammation. And the more severe ones will have ulceration. So if the inflammatory mediated attack is so severe, it will actually destroy keratinocytes and patients will have ulcers. Mm-hmm. What's special around the mouth is there is an academic argument raging in Europe in that lichen planus in some people's minds in the mouth is associated with reactions to dental amalgam, particularly the golds and the mercuries. So some of these patients who've got a lot of lichen planus are often seen by the dentist, and then the dentist sends them off to the dental specialist. So there is, for medical practitioners, there are dental specialists who are trained in dental medicine, and there's a few of them based in Perth, and a number of these patients get sent by their dental colleagues to these dental specialists. And then they send them on to me for patch testing to tell whether they've got a problem with mercury or a problem with gold. And frequently, if they're positive, the dental people then go along and remove all their amalgams, all their fillings, all the metal, and replace them with epoxies, which is a horrendously expensive exercise. Mm-hmm. And some of the European studies will show in 50% of patients that all their lichen planus will go away. Mm-hmm. But there are certain criteria for those people that we select.
Is it irritating in the mouth or is it just there?
A number of them are totally asymptomatic. So again, from my point of view, having a few white streaks in your mouth isn't a big deal. The natural history of lichen planus in the mouth is that it will often hang around for a year or two or three and then just disappear. Yep. So patients sometimes have noticed it themselves. Not uncommonly, it will actually appear on the vermilion on the lip. So when you're cleaning your teeth, they'll see a red patch or a violaceous patch or a little Wickham stria, and they may come to you as a doctor because they think it's skin cancer. So once you've seen the slides or looked it up and you've seen those images, they're very characteristic and quite easy to diagnose. Yep. If you're not sure, do a biopsy. Use some local anaesthetic. So if you want to be nice, you can put local anaesthetic on a cotton wool pledget like the dentist does, hold it against the mucosa for 30 seconds, then use some local anaesthetic and inject it into your marked zone. Keep the needle. So you keep your local anaesthetic needle, and what I then do is once it's numb, I put another little pledget in and puff it up like the pot orange effect, and then I use the needle to actually pierce through the skin. So what I've got is I've got a bleb of skin on the needle.
Yep.
And then you basically tent it up and you use your scalpel blade and you just cut along the needle. And the reason you do that is that your piece doesn't go flick and you've lost it, or the patient swallows and it disappears. You've actually got your tissue sample on your local anaesthetic needle. So then you just put that down so you know your sample's safe and you know where it is because it's always quite small.
Yep.
And then you just use your cautery or hyfurcation to the base. Don't bother with suturing it. And the patient has a little graze just like they bit in their cheek.
What about non-mouth sites? Where does it mostly occur?
Lichen planus on the skin traditionally is wrists, ankles, genital areas. It's very common for it to turn up. And it's usually papules, little nodules and little papules will have that characteristic purple colour with little streaks. And it's usually incredibly itchy.
So the purple pruritic papule thing really
does
a purple
exist.
pruritic papule.
Yes, really does exist. And then it starts to become more bothersome on the shins, and it's another one of those rashes where if you scratch, you just make it worse. And they can be quite acute. And with any of these things, it's an inflammatory, itchy process, so your topical steroids work the best if you're going to be prescribing a topical treatment. For mouth, access and application is always quite difficult. So there is a prescription Orabase, which is particularly designed for oral mucosa. I must say it's something I never use because I find it's extremely expensive. It's not on the PBS and it doesn't stick on the mucosa in any way.
It's that very sticky stuff that patients use for mouth ulcers, isn't it?
Exactly.
Kenalog and Orabase?
Yep, Kenalog and Orabase. So I just prescribe my standard prescription that I'd be giving them if I was treating their wrists or their eczema. So I'll give them their Alicon or Alufrat or whatever, and I tell them to stick it on their finger and rub it on the mucosa. I know it says in the information leaflet, it says don't stick it inside your mouth, but there's no difference. It's exactly the same thing. It's a lot cheaper. For harder to reach areas, I use QVAR inhaler, steroid inhaler, where it's hard to reach areas. I get them to pull out their skin, point the steroid inhaler and shoot. And what's happening is the little steroid granules in pulverized form embed in the mucosa, and
That's
it
ingenious.
works. The only risk with that is that you've got to be careful and warn the
They'll get
patient.
thrush.
Exactly. So some of those, just like your asthmatics, if they've got lousy technique, you can, if you're unlucky, get overgrowth of thrush.
There's other grab bags of dermatological things that turn up in general practitioners' surgeries, and one of the most common is the impetigo or the school sores, which can be very simple to treat, either with something topical, like a Bactroban or some of the other ointments, or can actually be incredibly difficult to get rid of. And particularly in little Aboriginal children that seem to have boils and pustules and impetigenised everything coming up everywhere. Do you have a kind of a Blitzen regime for the difficult impetigo?
Certainly. Impetigo is a classic one. Once you've seen 3 or 4, it becomes very easy. The first 2 or 3, you sort of wonder about and you think it's fungus or you're not sure. But the classic thing about impetigo, it's blistering, it's gooey, and they have that golden yellow sort of crust. It's a very characteristic colour.
Yeah.
If there's an isolated lesion, essentially if you go back and you think, well, what's the mechanism here? The mechanism is the patient has a infection in the outer skin layer. So it's an outer keratinocyte infection, so on the outside of the skin. It's usually strep, but in some communities we're seeing more and more staph. So the microbiology can vary. Essentially, they've been infected with a phage group of strep or staph that produces a chemical that dissolves the glues between the skin. That's what we're seeing. And often the bug gets into the hair follicle, it produces this exotoxin which then causes the cleaving of the skin. So when you look at the lesion where you see a blister, there are 2 components. The bacteria is actually in front of the edge of the blister. So we need to get all the goo off. So external care is very important with impetigo. So patients need to have some sort of regime, whether you're a peroxide person, whether you're a Bactroban person, whether you're a Savlon person, a salt and water and scrubbing brush person. You've got to get the dead tissue off because that's where the bacteria is living. and you can't really get topical therapy to penetrate through crust and scab and goo. So toileting, cleanliness, wound care is very important. So for me, I don't just use topical therapy alone. I always use topical and systemic. So I use topical antiseptics and a systemic antibiotic, and you need to cover strep and staph.
You've spoken intermittently about fungal infections, and I think probably the most common fungal infection we would see, apart from tinea pedis, I guess, would be the pityriasis versicolor, looking very, very red and icky and pigmented in white-skinned people and very depigmented in dark-skinned people. Is there a magic treatment for that? And because the pigment change seems to persist, how do you know that your treatment's worked?
Excellent question. That's one of those clinical things that comes up for us all the time. Pityriasis versicolor is a mould, it's a yeast infection. So, again, I have the same language problems, and sometimes I will say fungus, but it's a mould and it's a yeast. And there are two aspects. It's a genetic process and it's an infection. The reason it's there is because the patient produces the right oil, so they have the right sebaceous glands that produce the right substrate for this organism to grow. So this organism, and they've changed the names many a time. I'm of the generation, the organism for me is Malassezia furfur. It lives in hot, humid, damp environments. So it's a classic for anyone who's been to Broome or Bali or Phuket to come back with this rash, or underground miners or people where it's hot and sweaty, very prone to catching it.
Yep.
So it lives in certain areas, but it will only get established on your skin if you have the right substrate for it to live. So there's two aspects to that. It likes you, and you will go into the environment where it lives.
Yep.
So you will meet up with it again and again and again. So therapy-wise, it's very easy to fix, but you need to have a plan to stop it from becoming re-established. And frequently if you ask the patients, they'll go, yeah, my dad has this, or my brother's got this, or whatever, because you have to have the right oil, and that's a genetic thing. Topical therapies don't work terribly well. So what often happens with patients is you make the diagnosis, it's easy, you can confirm it, and if you're going to prescribe a topical therapy, great. But they need to treat their entire torso. So they need to treat from chin to elbow to knees, front and back. So if you have a single person, they can't treat their back. Many agents use, often we use peripheral foaming lotion because it's quite easy to get, it's over the counter, the patient can go and buy it themselves, and there are many different regimes. The packaging for peripheral foaming lotion says they should do it 3 days consecutively. I do it weekly. I tell them to do it once, and then a week later do it again, and do it again, because most people can fit that into their program. If you're working or you're busy to do 3 consecutive times, finding someone to paint and cover your back isn't that easy. So I get them to do it, apply it, leave it on for as long as they can, preferably 24 hours if we can, but at the very worst they put it on the weekend in the morning and have it, wash it off in the evening, and that always works. Systemically, we often use ketoconazole tablets. And again, many different regimes. My regime is I prescribe on a private script, because it's not under the PBS for this indication, 10 ketoconazole pills, and I get them to take 2. 2 will do it every time. So essentially the way they do this is they have a shower in the morning, have breakfast, and then take 2 pills at breakfast because it's absorbed with food.
So you're just taking 2 once only? Or
2 stat will do it.
And the other 8 are for the next time it comes back?
And the other 8 is the next time. So we get them to take 2, but then the trick is they must exercise. So for me, sitting in this nice, comfortable environment where it's air-conditioned, I'm not sweating. So the ketoconazole is absorbed with food, but then it sweats out. So if you've got some young lady, she goes, oh great, I'll do that, and then I'll go for a walk, and then the first thing she wants to do after that is have a shower. Pointless, because she's then washed off the chemical. So they need to exercise, they need to sweat, and you're trying to get them to sweat enough so this sits on the skin and not that they're stinking, because you don't want them to wash. And again, preferably for at least the day, and preferably to the next morning they don't wash. And if you get them to do that, you'll get 100% success. But your question, what happens is the mould produces a chemical which paralyses pigment cells.
Yep.
So a number of patients will complain of itch. That's easy. So therapy-wise, itch goes, they know it's worked. It's flaky and scaly. A number of patients can see that. But you need to actually counsel the patient at the time that they're with you that your treatment's going to fix their itch, it's going to fix the flaking, their skin's going to go smooth, but they're going to be spotty. And the reason they're spotty is because the chemical has paralysed their pigment cells, and it'll take roughly 1 to 3 months, depending on their skin type, depending on their skin coloration. So if you've got an Anglo-Saxon Caucasian, they don't even see it. But if you've got darker people with my skin, or Greeks, or Islanders, it's very, very common that they'll be white and blotchy for a month or two. And getting a little bit of sun, again, 10-15 minutes of sun once a day will stimulate their pigment cells to return.
And the other thing that we see is teenagers with pityriasis rosea, which is sometimes quite difficult to convince them that it's going to go away after 6 weeks, although it usually does. But could you talk a little bit about the characteristics of it and what you do for the people in whom it persists and persists and persists for a couple of months?
Pityriasis rosea is almost certainly another viral infection.
Yep.
It clusters, it clumps, so all of us who've been out there at the pit face, all of a sudden you'll see 3 or 4 in a week or 2, and then you won't see any for months. It's going around at the moment, which is a bit odd because we're in January. Yeah. I've seen a few this week, but they're very common in winter. What's characteristic, it's very nice if they've had a herald patch. So occasionally patients will say, oh, I had one big thing turn up on my back, or it's on my thigh, and that was there, but that's starting to go away, and then all these other things came up. So in real practice, what happens is you're sitting there in your chair, and this youngster comes in and goes, Kurt, Doc, I've got this rash. And you go, oh, yeah, okay, give us a look. And off goes the shirt, and there is rash everywhere. And you go, oh, well, I can see that. That's pretty impressive. How long you had that for? And they go, 2 weeks. Does it bother you? Yeah, it's ugly. That's what your patient will do. And there are 2 conditions.
Usually it's the week of the school ball.
Yeah, and there are 2 conditions that do that. Guttate psoriasis and pityriasis rosea. They're the only 2 where you're faced with rash everywhere, acute, and relatively asymptomatic, but ugly. And the difference is in the pattern. Pityriasis rosea is often like a Christmas tree. It runs sort of with the rib line. Yep. So it's an ovally thing, not round. So you'll get little oval bits that will run like a Christmas tree, and they're predominantly on the torso. It's unusual to get them on the thighs or the shoulders, and extremely rare to get them on the face. While guttate psoriasis is more regular, more circumscribed, more uneven. Pityriasis is quite pretty. And they've got sort of more reddy, angry sort of colour, and they're a little bit more flaky. And if you look at the lesions closely, and the best places to look is around the axilla and around the groin, where you've got the creases, often the pityriasis rosea lesion it's a little bit like a placemat with a plate on it. So you'll get the red sort of pinky round patch, and you'll get a little bit of flake in the middle, like there's a dinner plate sitting there. Yep. And that's very characteristic. While with guttate psoriasis, it's flaky and scaly throughout. So when you see that red bit with a central little bump, and some of them will blister and some of them will actually be hypopigmented, there's different variations, then you can be pretty confident about your diagnosis. Again, doing a skin biopsy is usually pretty useless for both of those. The pathologists aren't very good at differentiating. They don't see a lot of them. And unless you've got someone who's really good at saying yes or no, it's a useless test. So this is a clinical thing that you just have to go, that's it. Clinically, with both of these, topical treatments don't do much at all. But if you want to get them better, natural ultraviolet light is the best treatment. So if you're in the country, and again, 10-15 minutes, get your gear off, get out the back, get a little bit of sun, go pink, and that's the quickest way to make it go away. What we do in practice is we put them in the phototherapy unit because it's safer and simpler and more predictable, and you can eradicate guttate psoriasis or pityriasis rosea with about a week or 2 of phototherapy, and you might need another week or so of just natural sunlight. So getting into your boardies and going to the beach or going to the pool is actually the best thing to do. Most people feel like covering up. So if you look at them clinically...
So you're not terribly practical in Kalgoorlie in July, of course.
Yes. So, because they don't have it on their face. They don't have it on their arms and legs. It's always the covered bits. And that's because ultraviolet light actually makes it go away.
Treating molluscum, where we've always been told, prick the lesions with an orange stick or a needle and squeeze out the goop and put some betadine on it, which is fine, except if you've got a wriggling kid with 200 lesions. Can you comment on anything else that might work for molluscum lesions?
I can remember when I was a youngster at high school going with my mother and my younger horrible brother to the doctors, and I was given a toothpick and a bottle of phenol to fix his lesions, and it works beautifully. Yeah. Compliance is the issue.
Yeah.
Molluscum contagiosum, first thing, the name's wrong.
Yeah.
They're not mollusks, it's a poxvirus, and they're not contagious. What I mean again by contagious to me is bird flu. Someone coughs on you, you get sick. Someone in the family's got molluscum. You know, if you've got kids and they're young and you put them all in the bath together, okay, probably, possibly, maybe the other children will get it. First thing I need to stress to parents is this is a common, everybody gets it. And if you don't get it as a kid, you'll lob back up at 18, 19, 20, having caught it off a partner sexually, and it's all over your pelvis, and your motivation for getting rid of it is really high then. So if you don't get it as a child, you're going to get it later. So they need to get it and get it over and done with. In days when there weren't doctors, this was just accepted. It goes away in time, but the question is, what is time? The problem cases, the ones we all have, are the atopics. So the kids who've got dry, flaky skin or got dermatitis, they do have a problem at ridding the virus. And what happens is naturally when these things get knocked around or traumatised, the immune system starts to activate. So you'll actually see a traumatised lesion with a red ring. That's not infection. What I mean is it is an infection because it's a pox virus, but it's not an added staph or strep infection. That's immune system activation, killing it off. And once you actually do that, and that's what we were trying to do while traumatising these things are epidermal lesions, they have no pain fibres, they don't hurt, and anything that traumatises them, I often will tell mum to get an old toothbrush and when the kid's in the bath, just to scrub the odd little one. Just gently abrade it. We're not waxing here, we're not dermabrading, we're not sort of scrubbing grit out of their wounds when they've fallen off their bike, we're just gently irritating into it with a flannel. I've been in conferences where people got up and said we duct taped children. I always found that a horrific image of someone sticking duct tape on children and then waxing them. As a parent, I don't think my kids would be happy with that, but certainly any sort of light abrasion, light trauma is one way of getting rid of these. Some parents look at you in horror and say, my kid won't keep still. I go, what? When they're asleep, you go in and check them, squeeze 3 or 4 every time you do it, irritate them. We've all had the same lesions, just wash our hands. The betadine's plus or minus, that's really just to stop patients from thinking it's infected, because the next thing they get a big red one and they're off to the doctors and we're all busy enough. What does work is Aldara. Aldara has been published, there's numerous observational studies, large groups. Aldara is very effective, but is also very expensive. But we get some patients who are so desperate they want to do something, they're quite happy to pay for the expense of a box of Aldara. It's a private script. And you don't need a lot. And what you do when you're faced with someone who's got 200 lesions, what we're trying to do is get that immune system attack going. So what you do is just pick on 3 or 4 little lesions, or 6 in a little clump, and get mum just to put a minute amount of Aldara on those lesions after the bath every night. Aldara is non-irritating, it's non-toxic, it doesn't hurt. And we're trying to get immune system activation, which is trying to accelerate what happens naturally. And once you actually get that happening, normally then
all of them go.
They all go. The problem is the atopics. So if you're faced with atopic dermatitis and molluscum, your number one thing is you fix the dermatitis. So out comes the prescription steroid and it goes over everything. So don't worry about, I'm putting a steroid cream on top of an infection, because it makes no difference. Certainly you will dampen down the natural immune system attack, but what you'll often have seen is you'll see where they do start to go red, you're going to see dermatitis. And once you see dermatitis, they start scratching, the skin barrier is broken, so they will then seed more and more molluscum will grow because the skin barrier is broken. So the number one thing we need to do as practitioners is improve the skin barrier, and that's your prescription. Fix the dermatitis first.
Okay, just the last thing, and quite a different topic, and that's milia, that patients often get. They're often much more distressed, mostly about the appearance, of course, than the doctor is. Do you just reassure them, or is there actually something you can do to treat the jelly things?
There are 2 groups, well, probably 3 groups. There's baby milia, grandma's milk spots, which grandma and everyone knows, you just ignore it, it just settles down.
Yep.
Then you get the youngsters. You get the probably 8 to 25-year-olds. And normally you find they're face rubbers. I have a habit when I'm getting very tired of rubbing this way. Some people rub their eyes, little balls, but I'm one of those. And if you do that, you'll get 2 things. You'll get chalasia and you'll get milia. Because what you're doing is you're blocking off the apocrine gland, and what we're looking at, that little white mark, is concentrated apocrine secretion.
Yep. So that's what you can see in the picture.
That's what you can see. And then the other group is probably the actinopaths, the older generation, where really what we're looking at is blocked sebaceous gland activity. So these are the ones who've got a lot of elastosis, people who smoke, where they get very fine damage to the elastic tissue, and you'll see the bigger, thicker white dots, which is really sebum stuck in the skin because they've destroyed their elastic tissue. So with the young group, the very superficial lesion, picking at them and irritating works, but you got to dig a big hole. I've got a habit of sort of picking and mangling mine. There's something strangely satisfying about digging a hole in my skin, particularly when
just like squeezing zits for older people, isn't it?
Even better. When I'm studying or doing work late at night, I just have a habit of mangling myself. But if I was smart, using a 17 blade, which is the sharp, pointy scalpel blade, turn it upside down because the bottom is blunt, and you pick, like anyone who's been unpicking a hemline or a fringe, you just pick and you put a little cut in the top and it just pops out. But trying to scratch at it doesn't work, and pins don't work terribly well because when you put a pinhole in, all you're doing is puncturing it, and this is a very thick, firm, viscous. You actually have to put a little nick over the top.
Using a draw-up needle sometimes works quite well because you can get a little
because that's got a little bevel to it. Therapeutically, what we do is use topical retinoids. A lot of these people are atopic or have very sensitive skin. So if you've got someone who's got pale complexion, we'd use Steva A 0.025% cream. And they just use that every night for weeks and months. The problem with topical retinoids therapeutically is if they're too enthusiastic, they put too much on, or their skin is too sensitive, it peels, it burns and stings. So you tell them to use it at night because it photoreacts, so at night there's no problem. They use a very small amount and it's a consistency over months time thing, and it works brilliantly. And for the very deep ones, the actinic ones, topical retinoids for years, ongoing, lifelong, because it does two things. It increases elastic tissue and collagen production, but it also opens up the comedones. But frequently for those very deep ones, you need to do something manually. One of my colleagues, Dr. Peppel, did a study in England when she was a registrar where they hyfricated these. They actually just got the hyfricator in a fine needle tip or cautery unit and just went and punched little holes in these things, and that broke them up. It worked quite well too.
Kurt, thanks very much for joining us today, and thanks for the dermatology marathon.
Hope it's been of some value.
That was Dr. Olga Ward with dermatologist Dr. Kurt Gebauer, and a big thank you to Dr. Gebauer for his time and expertise. Well, that's all we have time for tonight. Now, don't forget that if you'd like to review this program or any previous program, you can watch them online or download them as a video or audio podcast via the Rural Health West website at www.ruralhealthwest.com.au. We're back again on the 2nd of March with the program on orthopaedics. So if you have any questions, please note them on your evaluation forms and return them to us as soon as possible. Thanks again to Dr. Kurt Gebauer and Dr. Olga Ward, and thanks to you for taking the time to join us. Good night.